Thank you very much for this invitation, especially Dr. Rohan. And I congratulate you for this wonderful web series, which is really the need for the hour and the advantage of Zoom at our doorstep. So it helps us to do this. I also thank you for inviting me to speak on pediatric refraction, which I think is very important because sometimes somewhere you will see a child where you would really need to handle these children and know what to do and how exactly to do. So I'm going to be talking about pediatric refraction, when and how much to correct. At the outset, we have to understand that glasses in children is different from that in adults. And why? Because there's a difficulty in obtaining a reliable repetitive visual acuity. It's sometimes difficult because the child can be really uncooperative. So for that, we have certain equipments like these retinoscopy racks. These are basically concave and convex lenses in these different numbers from 0.5 to almost 6, where you can do a quick refraction holding the child and you can get an approximate idea, which is very mandatory, especially if the child has a very high refraction. Then different visual demands, because in certain adults, we can avoid glasses, but that cannot be done in children because they have a very plastic visual cortex, which is vulnerable to amblyopia, that is development of lazy eye. They can develop squint and lose their binocular vision. So hence, glasses in children becomes very, very important. At any age, we should be able to decide whether to give glasses or not, and hence the talk today. But remember, prior to that, a cycloplegic refraction is a must. And whichever you're comfortable with in your clinic, you can use, but that is mandatory before deciding on glasses. Let's understand the various refractive errors in children. And I shall take you through myopia, astigmatism, hypermetropia, anisometropia, and special scenarios. Starting with myopia. So let me try and explain the same thing in different case scenarios, starting with an 8-year-old boy who had a difficulty seeing since 2 months. As you can see, the vision is less for distance. Pinhole is good enough. Always remember that when you're doing a checking for children, do always a Hirschberg's test and do a cover test to see if there's squint or not, which is very mandatory. Yes, there is no squint here. The patient has a refraction of -2 in both eyes. So very simple, you check the cyclo-acceptance. He needs it. Both eyes are myopia and you give glasses. And you review after 4 months initially to check if the patient is seeing well. Change of glasses. Thereafter, a yearly checkup is also okay. Now let's look at a case scenario 2. A 1.5-year-old male child having a preterm, and we expect with preterm myopia coming up, had a history of neonatal seizures. Ocular examination shows that central steady maintained, that's the CSM, and no resistance to occlusion, telling you that equal vision in both eyes. So as I said, always look at squint, and that will also decide whether you really need to give glasses at that time or not. So no squint, no nystagmus, everything is perfectly normal. And his refractive error is -2 with -1 in both eyes. So you see it's similar to the child which we saw was 8-year-old, but this is 1.5-year-old. So what do? Reassure the parent, do not give glasses, wait and watch. Because for this child, all what he's interested in close viewing. For him, his life is really in close quarters. You don't really have to worry about 6/6, so you don't need to give glasses, but you have to review him 6 monthly and tell the parents don't addict him to gadgets, because that's the common thing which is coming up now. So then the question arises, what is the ideal age to prescribe myopic glasses? What is the ideal power to give? And do we have any advice for progression? So let's address the first 2 questions. So this is the guidelines. And remember, when you're giving glasses, you have to consider 2 options. 1, similar refractive error in both eyes against unequal refractive error in 2 eyes. So not getting confused by this busy slide, let me tell you a simplified method. If patient is under 2 years and isometropic, that is same refractive error, anything more than -4, you give glasses. And between 2 to 4 years, anything more than -3. But there's an anisometropia. That is a difference between the 2 eyes. One eye is going to be normal, and anything less you should give. So more than 2.5 less than 2-year-old, and more than 2 between 2 to 4 years should be given. Let's look at this child, 10-year-old boy, blurring of vision, not reading 6/12, and with 6/6, he reads about with -1.25. So do we give glasses? No. Remember, as I mentioned, cycloplegic refraction is a must. And remember, just never give glasses purely. In a child, even if they come and tell you, I have exams, can I give glasses? Please don't give. Because this patient has pseudomyopia. He would be reading a lot prior to exams and landing up with glasses. So when you have a patient with pseudomyopia, avoid manifest refraction because that will cause more and more ciliary spasm. Tell them to follow visual hygiene, which is the 20-20-20 rule. Take rest. Distant vision activity should be increased. Keep reading materials far away. And even if after giving all this, if the patient continues to have this myopic tendency, give him cycloplegic eye drops. So never prescribe them. Hence, important here is do cycloplegic refraction. So what do you do when you give glasses in myopes? Never more minus than your cycloplegic refraction is the first point. So do not overcorrect. Glasses given if vision is less than 6/9 or if refraction is more than -1. So anytime like this, you will have to give glasses. And if in doubt, you can call them back after 4 months. see them and give. So in children, sometimes you're not very comfortable. You don't have to rush and give. Give them time. Let them come back, and then you can give glasses. So always take time. There is no sense of hurry. Now, that important question: how any advice to prevent myopia progression? Now, there's a study which was done by the Brian Holden team and published in 2016 Ophthalmology, which shows that South Asia will eventually have by 2050 53% of patients having myopia, and India comes in this. In fact, if you look at the impact of COVID pandemic, where it is shown this is years of the age of the child against the spherical equivalent, if you notice from 2019 to 2020, look at the sudden increase, and this is because of the home confinement. So we are aware that the patients are getting more and more myopia. Hence, we have to do something to prevent the progression. And what do? Encourage outdoor activities for 2 hours. Yes, sometimes parents are very anxious not to send their child. Don't worry. You tell them that spend time sitting in the balcony or sitting looking out of the window, because he has to intermittently look far to relax the eyes. Follow 20-20 rule. Keep reading material, whether it's studying, drawing, coloring, anything 14 inches, and intermittent breaks with distance focusing. So this needs to be reinforced with every child. Now, coming to the next important aspect, astigmatism. A 6-year-old child, blurring of vision and squeezing the eyes, had a vision less. Now, you notice the previous case, scenario 1, had a vision of 6/36, but pinhole was good. Here, the pinhole is less. And again, you check for the squint, not there. You see the refractive error, significant astigmatic power. That's why the pinhole vision is not very good. These patients have to be given glasses earlier. So in this case, a patient has come at 6 years. Yes, you will be giving him glasses. Prior to that, get the K reading done, because you need to know the cause for this. Is it a lenticular? Because that will not get corrected by glasses alone. But if it is corneal, you need to give glasses and the patient should be fine. So regular astigmatism, give glasses and call him 2 monthly to see vision checkup or to introduce exercises if the vision does not improve after 2 months. So what are the guidelines for astigmatism? As you can see, under 1 year, more than 3, 1 to 2 years, 2.5 or more, and 2 to 3 years, more than 2. Now, the third important, hypermetropia. Let's look at case scenario 4. An 8-year-old boy wearing glasses since the last 3 years. You can see the glass power is +3 in both eyes. Vision is good. He is again orthotropic, no squint, and rest everything is fine. Look at the refractive error. Now, the glasses given are almost +2 diopter, less than what is required. So in a patient who's hypermetropic, you need to give glasses as much, the minimum required for him to read 6/6. So sometimes if the patient even reads 6/6 with +1, it's fine. If he develops astigmatic symptoms in future, then you can add up this up to +5. So what do? Yes, diagnose as hypermetropia and ask him to continue glasses and review after 6 months. Let's look at case scenario 5. A 4-year-old boy developing squinting since 6 months, and you see the vision is less. Now, when a 4-year-old boy comes with squinting, remember, why does that happen? He has an esotropia, if you notice, which is about 20 PD for distance and near. So as a child gets older, his interest in exploring things starts improving. He wants to notice things because of the presence of this, he develops a squint. Now notice the EOM is full, that is the extraocular motility indicating a comitant esotropia, which means this is not something like a 6-nerve palsy. So we know this is related to the glass power. So what we need to do, the refraction, and if you see, it's a hypermetropic power. So somebody who has a plus power wants to see better as he grows will land up developing a squint. And this will happen only of a shorter duration as and when his interest increases. So what do you do for him? Give glasses, you give full correction and do a squint assessment. Now post squint with the glasses, if you do the squint, you notice the eyes are absolutely straight. This is a classical example of refractive accommodative esotropia, and the glasses completely correct the squint. So this patient will need full correction of glasses. Now let's look at a similar scenario. 6-year-old girl squinting since 1 year, no history of wearing glasses, vision is not as bad, has a left eye squint, similar like a comitant esotropia left and going into alternating. See, the amount of squint is now less, and the refractive correction in both eyes, that is a cycloflash, is also about 2.5. But you notice the vision is not significantly less here. So as we learned, when there is squint, we'll give full correction with glasses, as you can see, and call him after 6 weeks for cover test. So cover test done for distance does not show significant squint. But for near, the squint tends to be there. That means squint is corrected for distance, but not for near. So what do? You give a trial of bifocals. So you give bifocals which cross the pupillary axis so that he, whenever tries to attempt to see for near, the squint gets relaxed. And if you see, the squint has disappeared, indicating that this is an accommodative esotropia with a high AC by A ratio. Hence, when you're giving glasses, especially hyperopic glasses, check the squint before and after the glasses for distance and near, because then accordingly you will plan. And remember, once you've given the bifocals for an accommodative ET, Ensure that it cuts the pupillary plane because you want the child to forcibly look below it. Otherwise, he will not want to see it because his vision is not the problem. And secondly, you need to taper off the bifocals before he enters the teens. So what are the guidelines for hyperopia? That will depend entirely on the presence of a manifest deviation or not. No manifest deviation, you can wait easily up to 4.5 between 2 to 3 years and up to 6 in less than 1 year. But if there is esotropia, you need to even give glasses as short as 1.5 after a spear, between 2 to 3 years, 1 to 2 years about +2, and 0 to 1 years about +3. Now let's go to anisometropia. A 9-year-old came with sudden vision loss in the right eye, wearing glasses. You see the vision is significantly less in the right eye compared to the left eye. The patient has a right exotropia as classically seen, and look at the refraction. It's +7.5 with -0.75 still in the right eye. Left eye is almost kind of plano, and you do a cycloacceptance also. So what is your diagnosis then in this case? Hypermetropia right eye with anisometropic amblyopia and sensory exotropia. Now notice the patient has complained only 2 months ago. That cannot be true. So you need to even probe and find out how that happens. So many a times you will come to know that incidentally the child has closed one eye and realized he cannot see, because this cannot happen overnight. So this is what tell you that this is not since, this is definitely since birth. And how do you advise? Give glasses or contact lenses. Now remember, if this is an axial related for which an axial lens is mandatory, then glasses will work because according to Knapp's rule, the image size remains equal and the patient will be able to fuse well. But if it is related to any lenticular problem, in that case, you may need this to work, and you or a related issue, you may need to give a contact lens. You give patching for the left eye and review after 3 months to see if it tends to improve. So what are the guidelines of anisometropia? You need to understand it differently for myopes, hypermetropes, and astigmatism. And between 0 to 1 year, anything between 2.5, whether it's plus or minus or astigmatism, should be given. Now, 1 to 2 years, myopia up to 2.5, but hyperopia and astigmatism up to 2. And 2 to 3 years, 2 for myopia plus 1.5 for hyperopia and 2 for astigmatism. Now, you need to know why would you have a unilateral error? Yes, one is antimetropia or anisoconia. Antimetropia is one eye is hyperopic, other eye is myopic. And this will cause astigmatic symptoms, fusion capability without lens correction, and best unaided vision of the hyperopic child is what you have to look at. But anisoconia is difference in the image size between the two eyes, which is not much common in younger. But as I explained, if the Knapp's rule works for an axial problem, but otherwise you may need to give a correction with contact lenses. And the final part, the special scenarios. Let's look at these cases. A 4-year-old with defective vision and occasional squinting, not using glasses. Vision is 6.9 in the right eye, but 6.18 in the left eye, indicating that could be the squinting eye. Ocular motility shows Hirschberg is central, but a cover test shows an intermittent divergent squint, and it's about 10 PD exotropia. The stereopsis is still good. So do a cycloflash and you'll notice there is some sort of a myopia which comes in. And like when there's myopia with an intermittent divergent squint, you need to know that by giving glasses, you can control it. So both eyes myopia, intermittent exotropia, and you give glasses. But I want to show you how glasses really work, because you need to call them back at 3 months and see if the squint is disappear or not. So when you're doing an alternate cover test here, you can see that there is no squint absolutely. But when you lift the glasses, you see the left eye drifts out, and you can easily make out the low vision in that which was initially there. So how well a squint, which is exotropic, gets controlled by giving myopic glasses. Now let's look at two similar scenarios. One is a 6-month-old baby underwent lensectomy in both eyes. 7 days after the second surgery, both eyes are quiet. Then immediately you look for the post-dilatant flash. Here we have not put in an IOL. You have a refractive error as mentioned. You need to give glasses. But remember, because anytime in any of your practice, you will be operating some child or the other. So remember that if it's a child and it's less than 6 months, you don't need to give bifocals. You have to give single vision glasses with +3 add. So this is the refractive error. In addition, give alternate eye patching, because you don't know which eye is going to be better than the other. That should be for minimum 2 hours daily. And you review every 3 monthly to see how the vision develops. So a little recommendation that if there is a patient who's undergone cataract surgery, if it's less than 1 year, give single vision glasses with +3 add. If it's 1 to 2 years, give single vision glasses with +2 add. 2 to 3 years, single vision glasses with +1 add or bifocals, because nowadays schools are starting, as in teaching is starting even before 3 years. So you can decide, and bifocals can be introduced earlier, but definitely after 3 years, bifocals. Cryptop also does well, because a child automatically understands that he has to look through the lower segment. But in certain children who are delayed in development, you can do a D bifocal. Now, another scenario, similar, but if it is a unilateral cataract, that means only one eye has undergone cataract, the other eye refraction is normal, you need to give contact lens for the right eye followed by patching. So remember, in this case, you cannot give glasses here because there is an anisoconia. The image difference between the aphakic correction in one eye will be significantly different. Yes, children can adapt well, but that is not our criteria. We want some amount of good fusion to develop, some amount of stereopsis to happen. So please give contact lens in the right eye, followed by patching to reinforce the vision. Now, case scenario 10, a 5-year-old male undergone penetrating corneoscleral wound repair 3 months ago, underwent cataract surgery a month ago, has a corneal scar. It's aphakic. Fundus is normal. So you can see with plus 18 is 18 the vision, and plus 11, sorry. And this is a refractive error. What do you do? Contact lens for the right eye. Remember here, again, same thing. Aphakia, unilateral, you have to give contact lens. The other advantage of giving contact lens here is there's a corneal tear repair done. So this contact lens will help coat that surface and make the surface regular and help in seeing. And you give bifocals for the right eye, plus 3 near ad for right, plano for the left eye, and patching should be done. So in certain scenarios like here, when the child is already developing some amount of amblyopia, patching can be started immediately to reinforce the vision. Eventually, you should be able to put a contact lens in this eye so that, a permanent lens in the eye, and then balance the refractive error accordingly. And finally, this case scenario 11, where a 5-year-old child came for congenital cataract, underwent IOL implantation in both eyes. Ocular examination showed eyes acquired post-surgery, but some amount of esotropia present in the right eye. Vision is basically less in the right eye compared to the left eye, as you can see, and a refractive correction. Yes, so here you will give the full correction. You will give bifocals with plus 3 add and the left eye patching. So remember here, you are not giving alternate eye because you know, or even in unilateral cases, you know it's the one eye which is problematic. So you need to just close the better eye to give the best effect to the child. And in children, you need to follow them up more regularly because the effect that can come also is good. And if the parents are a little more not motivated and not really doing patching, then you will not understand exactly whether the vision. So call them more often in children when you really want to know. Also, sometimes your retinoscopies may not come very good. Don't worry, as I said, call them back after 3 to 4 weeks, repeat it. And once you get 2 readings which are matching, you can go ahead and give. So whenever you have a refractive error and symptoms like fatigue, burning, headache, limited reading tolerance, remember we are either looking at an astigmatism, an anisometropia, or a muscle imbalance. So hence checking of all this is very important. Now, whatever these guidelines I have told you are something which have been put in by American Academy. But keeping that in mind that this was long ago done, we, the pediatric ophthalmology expert group, decided under the leadership of AIOS to have our own national consensus statement, which we published in IGO in 2020. And then we realized how we can use it for our population. And this is much simpler. So this is like the take home. So if you have an isometropia with myopia, anything more than -3, irrespective of the age, you will give. And for over 2 years, depending on the refraction. If it's anisometropia, again, more than -3, and anything over 2 years as per refraction and as per the vision. If the patient is on the other hypermetropic and isometropic, anything more than 4 if it's no manifest deviation, and anything more than 1.5 if there's esotropia. On the other hand, in anisometropia, anything more than 2 for under 1 year and anything more than 1.5 for over 1 year is to be considered. And finally, for astigmatism, more than 2 under 1 year and more than 3 under 1 year and more than 2 for isometropic refractive errors. And if it's anisometropia, anything more than 2.5 under 1 year, so just 0.5 more than 1 over 1 year. So basically, remember, yes, we have these guidelines, but these are not 100%. You need to individualize per age, depending on the child's growth, his education status, depending upon his mental status. All this will define what you really need to do. So when do you time for screening? Neonates at discharge, high-risk cases within a month. But between birth and 3 years, one screening by an ophthalmologist is a must. 3 to 5 years of comprehensive eye examination by an ophthalmologist at least once, and 5 to 8 years will be done. So ideally, every child should have got one checkup done under 3 years or definitely under 5 years. And this is why guidelines that we have eventually published. So now final thing is, what tips do you give for spectacle selection? Remember, you need to educate the parents very well. Sometimes they feel it's a disease and you need to understand that it is not. Wearing glasses is something as simple and that is important for that child, and eventually you can definitely remove them. Also reassure them that once the child starts wearing glasses, he will appreciate the difference and he will accept and wear the glasses, and his life will also change. And many times the parents realize that and they come back and give you the same feedback. Remember to choose a shell frame because that leaves less marks. A proper fit and comfortable is very, very important. And use the plastic or polycarbonate. Polycarbonate are a little expensive, but they can use a CR39 initially. But unfortunately, they are not scratch proof. Once the number remains stabilized, you can go to polycarbonate. Remember, a glass should not be like this, fitting down. So what you need to understand is look at the temples. Beyond it, it should not be crossing the ears. Otherwise, you can easily, and how do you check it? By pulling it in front. It should not sit on the neck. So this are important things that we need to look at, because if we tend to not see all this. Once, the child will really not use a glass, he'll look above it. And secondly, the effect of using a glass will not serve the purpose, and they'll start rejecting the glasses. So how do you select a frame? A frame which is round or oval, which sits comfortably on the eye, such that it covers the eye completely and the eye is at the center of the frame with the height at the level of the eyebrow. You should pull and see, they should not come in front. And if you look at the temples, they should be right snugly fitting around the ear with a headband. So if you have a glass like this, you know the child will see through it and it will serve the purpose. So the final take-home message is cycloplegic refraction is a must in a child. Spectacles to be given depending on the visual needs, and use a correct frame and a correct glass for every child. Risk of amblyopia to be explained because that's very important, and hence children should be given glasses at an early age and treat if present. Thank you very much for a patient listening.
Thank you so much, ma'am, for the informative presentation. And thankfully, this is a recorded webinar because we'll go over this again. It constitutes all the aspects that we can encounter in pediatric cases. All your 10 cases are pretty much, they sum it up of when we should be giving glasses and how should we be prescribing glasses to youngsters. I would like to welcome Dr. Himanshu Mehta, sir, President of IRSI, who's joining us on the show. Sir, your thoughts on kids, how to do a refraction on kids, because this scenario has changed. And especially in the last 1.5 years, 2 years, ever since COVID hit and lockdown came in, I mean, the requirement is more for intermediate than for distance, because all that blackboard, looking at projectors in classrooms, all that is over. So the requirement has now shifted to near vision and intermediate vision. How do you tackle? I remember there was a patient in your clinic when I was around, such a smart kid, and all that kid wanted that, I want to see my iPad clearly. I don't care about anything else. My world is iPad now. So, how has the scenario changed in the last 2 years?
Refraction is a most neglected subject in the junior age group that I've seen over the years. In our training, first 6 to 8 months, we were in that Lal Batti room in KEM. And so Jyoti is smiling, right, Jyoti?
Yes, I remember. Yes, I actually did that, and literally almost Lal Batti, and then as seniors, we went to the other side. We only did retinoscopy, and I really believe that my retinoscopy is so good. I can do keratoconus also, just looking at that, yeah.
This is what I'm saying. We used to hate it. It used to be hot, stuffy, dirty. And the worst is everybody. The ward boy gives you gali, the sister gives you gali, patient gives you gali. It's a closed room. You can't see anything. And those oily bhaiyanis come with a lot of oil, and you have to keep doing those refraction. You don't understand a damn thing. And yet, but as Jyoti said, whatever it is today, without an AR, confidently that we can give an access and we can give a number without doubt to a patient. And thanks to that training, and that is missing big time in the younger generation. They're all dependent on either the optometrist, easiest thing, passing on the buck, or they send it to, like a policeman. Go there, go this room, go to that room. So, or the auto ref. The easiest thing is the auto ref. Never do they do their own refraction. If I was to put 100 postgrads right now, I promise you that most of them will not come with the correct answer. This is the unfortunate part. When cycloplegia, when tropicocele, when what, why this for the child, why not for the adult, what is what, classically our time was aphakia. So giving +10 with +2 was like, what she explained right now, +23 with -2. What Jyoti gave. It's something very simple. We used to do that routinely for every patient. Even the axis, there was nothing. So a streak retinoscope was like a luxury. We used to have that a regular retinoscope. So brilliant, Jyoti. What she said is something very, very important for everybody, because pediatric population is 40% of the population, and every ophthalmologist is going to get it. You're not going to keep referring them to Jyoti every time, unless you have complications, you have problems. Brilliant presentation, Jyoti. I must compliment you. My regards to Himanshu also.
Yeah, sure. Thank you. But that's very true. Actually, as an ophthalmologist, you'll always see a child. You get a family, even if you're seeing adults, they will get their children and say, please see. You would have operated some child with a cataract or something. So you at least have to know how to handle them, because they are in the growing phase. If you don't know what to correct for them, then their entire life, is dependent on you. So you need to have it, and all it is to understand what to do. So that's important.
When homide, when atropine, what is the squint? And most often than not, few pediatricians, but most grandparents and everybody is under the opinion that when a child develops squint, kuch nahi acha ho jayega 2 saal mein.
Yes.
And unfortunately, if you are very clear and you told the parent, if you come in the first 15 days, I have reverse squints. And I'm sure Jyoti will agree with me that by simply giving numbers at the right kind of number that you give, you can reverse. The other thing you mentioned was bifocal progressive glasses or a bifocal glass. The optician says the doctor ka dimag ghum gaya, and they try to be dead shana, but digest this. It makes a huge difference in almost all my pediatric cases that I see with squint. Their spasm of accommodation for reading is so much, and the amount of accommodation, that if you give +2, +3 kind of, their muscles are very strong. So you might have to give even stronger for their accommodation. And that's why a multifocal would be a great help to a child. Every word she said, you need to go back again and again, because there's a lot of wisdom in those last 10 minutes, what she spoke about every particular example. Beautiful presentation. Thanks so much. And a lot to learn from every point that she mentioned. Forget cataract. You may not be doing cataract surgery, but to prescribe to these patients, because you are going to get them. And pediatric age group is a very important age group, and the parents will love you, because if you've done something good for the child. Yeah, one more thing that I want to tell you, will have to be, like she said, to call the patients for myopia correction, because out of love, when the child is cribbing and crying, the mother or the grandmother or the grandparents, अरे छोड़ो ना, doctor बोलता है नट लगाओ, वो पैच मत लगाओ, बच्चा खराब दिखता है. And I have to tell the parent that, look, today out of love you are doing this, but at 18 the child will tell you that, why did you not slap me?
Yes.
You are wrong.
Yes.
I am not wrong. I was a child. You should have done this to me. You should have slapped me and made me read. And yet parents don't come to you because you are strict with them. So very important to follow up regularly, see how well you're correcting. And children respond like this. And another thing I promise the parents one thing, that the moment your child doesn't crib about glasses, he's got used to glasses. That means it's the correct number. It's the correct shoe size. You don't have to worry about it. So you will have to be a lot of counseling, a lot of psychology, because first thing earlier on, mothers used to start crying when I used to give a number. The biggest thing, I was the biggest enemy of most mothers. All the pretty mothers used to hate me, because they cannot digest that, you've given a number to the child. They would start crying. In the last 10 years, after Deepika and all have started wearing glasses, you can say, look, they look pretty. Things have changed, but it used to be a different scenario. Especially a girl child getting glasses was like a taboo earlier on. So you will have to do a lot of counseling. You'll have to be the psychiatrist. You'll have to be the counselor. You'll have to be the ophthalmologist and get a correct number. Children, most unpredictable behavior. They will keep moving. They will never be steady. You might have to call them twice. You will have to have patience. They'll break your ophthalmoscope. They'll break many things. So I made a child-proof room so that they don't break many things. So be careful about that. But wonderful, Jyoti. Thanks so much.